And so without further ado, let me introduce Dr. Kimryn Rathmell, who is our current director of the National Cancer Institute. Dr.
All right, thank you. It's such a pleasure to be here, to be honest, and to follow Jeff. I don't know where you are. You're here somewhere. There you are. That's a powerful story, and it's important to hear the ways that this experience affects people, families, and communities. And so, I want to thank you for what you're doing, for taking the time to be educated about stomach cancer, in particular, a really devastating cancer that we need to do more for. And then tomorrow, taking your time to talk to our members of Congress as well, to make sure that they are also aware of how vitally important it is that we continue to make advances. So you heard, I'm Kim Rathmell. I'm new, so I thought I'd actually start by introducing myself a little bit, not the resume side of things, but because I think it's important that you know who are the people who are doing some of this work. So I've been a cancer biologist for some decades and working in the area of kidney cancer. I got excited about being a part of a cancer that we could make basic science discoveries, move the needle for patient care, and been glad to be a part of a sea change that's happened there. I'm a medical oncologist and have treated patients with genitourinary cancers, but predominantly kidney cancer and other more complex versions of that disease. I've been an educator and worked with trainees, and that is a big focus area for me. It's the young people who will be taking us into the future. And then spent several years as a health system administrator, trying to learn how we actually deliver care and get the kinds of discoveries that we want moving forward. I love basketball. I don't have good basketball analogies in here, but you will see that I like to use those. And I'm from Nashville. So Taylor Swift's from Nashville too. She's more famous than me. But but I like Taylor Swift for a lot of different reasons. But I particularly like the current tour that she's on or wrapping up, representing eras and her various eras. Because I want to talk about how we're moving into a different era and how the NCI can be a part of, along with advocacy groups, how we change the dialogue and really move science in a different way to make a big difference for cancer. So we have a lot to be optimistic about in this space already. We know that year over year, we're seeing improvements in cancer mortality. So that's what this graph shows steadily. And that only happens because of foundational science, novel and innovative clinical trials, and communication and education, and bringing all of those pieces together to make a difference. We can also be optimistic because the kinds of science and the kinds of advances that are on the at the cutting edge are real and make a big, big difference. Immunotherapy, like touching almost every cancer. And we have now a dozen different ways to use immunotherapy. And so figuring out how we're going to do that will be changing things just so dramatically. We have tools like novel genetics and AI and ways that we can understand patients and populations of patients that we never could do before, and we can very, very rapidly. We also face some really serious challenges. This graph is showing the rise in cancer in young people. So cancer doesn't stand still. We think we've learned everything, and then it turns out cancer is just a little bit different, and that's the way it always will be. That's one of many areas that we're very focused on, trying to make sure that we can really, truly understand what's happening in this space. But we're also confronted with some bigger societal issues around financing this very expensive work and being able to have the workforce that we can need to move this forward, and trust in science and helping to be able to be clear, especially as it gets so much more complicated, so that communities can really understand and trust what it is that we are trying to say, and moving into a place where we have more dialogue. I just wanted to point to a couple of really groundbreaking changes that are happening. I already mentioned immunotherapy. Let's just talk about AI for 1 second. We know that AI is moving into clinical spaces. This is an example from a recently published clinical trial or a clinical study that showed that applying AI diagnostics could outperform any of the other prognostics that they were using for this particular tumor type in terms of what drug response would be expected. We are going to see more and more of this. Knowing how to use it, when to use it, how to do it safely, and how we put appropriate guardrails around patient privacy are all things that we'll be facing. The other picture that I show on the right with the little FNAC2, this is a really groundbreaking discovery as well of a space in between called the microbiome. We know that we all live with lots of bacteria in and on and around us. And those bacteria have real importance in how our diseases and health is manifest. This is an example just from a couple of weeks ago of a particular microbacterium that was found to be very tightly associated with colon cancer, and maybe one of the reasons that we're seeing shifts in the kinds of people who are getting colon cancer. So understanding this is also some of the work that's really, truly groundbreaking and going to make a big difference. So what's changed and why this matters and is the era that I'm talking about. We all can point to an era of medicine and science that used to be very top-down. This knowledge was thought to be held by a few, that we conveyed to others. It was very narrow and specialized. I would say where we've been living for the last decades has been in an era, popped right up, that I would define more as horizontal. Lots more collaboration, lots more of sharing across fields because things started to get too big. Interdisciplinary research, we all know, is the real power. Patients can't complete a full course of therapy without a whole host of doctors, right? The team is what really makes it work. But what I will say is that I think the next era that we are moving into, there we go, is what we're calling 360, because it's really moving into an era where we embrace more ground up type of ideas, actually engaging more with advocacy groups as partners, not as people who need to hear some special wisdom that we have, because you have wisdom that we don't have. We need to learn it all together. Recognizing the fact that the population doesn't just accept what we say, there's access to information at our fingertips everywhere, and knowing how to help everyone know where to go to find the most relevant information. I think this is the next era, and this is where we'll bring AI, immunotherapy, microbiome research, complex genetics research to make big and bold and faster advances for patient care. So this all fits into what we use as our roadmap, which is the National Cancer Plan. I really want you to know how we use the National Cancer Plan. The National Cancer Plan's been around for a year, so it's fairly new. Just rolled out a year and a month or so ago to put together a roadmap. So the National Cancer Plan is shown right now with just an arrow. It's meant to convey forward momentum. It's meant to help us figure out a direction to go. It has 8 goals. First, I'm going to tell you about 4 of them. So the first 4 goals define the arc of the patient experience. Preventing cancer. Best cancer is the one that never ever happens, right? Detection of cancers early, detecting them early so we can manage them better. Developing novel and important therapeutics that work, and improving the patient care experience. So if we can do all of those things, we will have made a big difference for all cancers. But how do you really take that up a level? So that's what we're calling the empowering goals. So think about how these goals will impact the health-centric goals. Maximizing data utility. We have so much data out there that we can tap into to make important discoveries that will impact prevention, that will take us into early detection, and we use all the time in giving us direction for where we're going to make advanced therapeutics, for example. A next goal, eliminating inequities. So we can't make the kind of forward progress that we want to make if we're leaving populations, communities, or groups of patients behind. We really have to be conscious of including all people when we're making these kinds of advances that we want for cancer. Optimizing the workforce. This is critical. We have to have a good pipeline of scientists, of clinicians, of people who want to be a part of this in every aspect of the cancer space. And finally, my favorite one, which is engaging every person. This one I think is a little bit of the outlier and maybe surprises people to think that engaging every person has to be one of the top 8 goals of the National Cancer Plan. But it is, because again, back to the fact that everyone has access to information. So they need to be engaged. They need to know how to trust, know what to trust and what information they need to be healthy, what information to share with their doctors and how best to interact and how to be a part of knowing their own risk for cancer. Now, all of this is driven by discovery science. We know that the discoveries that we make today, some of which we can't envision how 2 years or 5 years or 10 years from now will have breakthroughs that will be important for cancer patients. But that discovery science is part of all of the empowering goals and feed right into the health-centric goals. And it's all together to improve health outcomes for everyone. Okay, so let's talk about how we apply the National Cancer Plan. So I have just some examples from stomach cancer that kind of work their way through the science and discovery into the clinical space. So first, understanding the earliest biological changes in malignant transformation. So we can't take care of anything that we can't understand. We need to understand the evolution, we need to understand the platforms for how this cancer forms, and to develop new collaborations in this space. So we have lots of examples of programs that are working here, and this is an example of the program on origins of gastroesophageal cancers. Clinical trials are the mainstay of how we make discoveries get directly into the hands of patients. These are some examples of new GI trials in our National Clinical Trials Network, we call the NCTN. There is no other part of medicine that has such a well-integrated national collaborative of clinical trials together. So across the nation, these trials are opened up, looking at novel therapeutics, immunotherapy, and other advanced immune therapies for stomach cancers. We also have other opportunities to advance clinical research in stomach cancer. We had an ad hoc working group that was brought together to make specific advice. So I have 6 boards that give advice to the NCI. One is the CTAC, the Clinical Trials Advisory Committee, and they recognized that gastric cancer was among the cancers that was not moving at the same pace that it needed to. And so advised an ad hoc working group, and their recommendations were to push hard still in laboratories and laboratory analytic methods, developing computational approaches to move some things faster, a biospecimen repository, and developing more model systems so that we can test things in real time. And those things are taking place and happening. In the space of clinical trials, we're looking, this is across the board, not specific to stomach cancer, but how do we make clinical trials more adaptable, more available? How do we make more access in communities that may not have a major academic medical center, or for patients who are not part of a cancer center? So this is a few just examples in how we're modernizing clinical trials. I want to point to the virtual clinical trials office, which is one opportunity that we learned from the COVID pandemic. In the pandemic, we learned that sometimes you can have one person who's virtually at multiple clinics, whether that person is doing data entry, screening patients for eligibility, doing some of the regulatory work, and we can distribute and provide more service in this way. That's a pilot that we're participating, that's the virtual staff support, just as one example. Also working closely with the FDA to make sure that we can do trials as efficiently as possible and to know what midpoint data collections are really necessary so that we're not collecting unnecessary data, both because that's not good for the patient care and that's also maybe not necessary for the clinical trial. And so we want to be proactive in making those determinations. I also want to make sure that you know about the SPORE network. So this is one network of how we fund clinical research in the NCI. So the SPOREs are major programs. It's a specialized program of research excellence. So they're institutional, or sometimes a few institutions partner together to develop multiple programs that come from immediate foundational discoveries and lead to clinical trials that they're testing in much more real time. So this is the space in between the discovery and getting something where it's headed to commercialization, but needs to be tested in real patient spaces. So these are examples. These are our specialized programs of research excellence that all focus on GI and stomach cancers. We also recognize that part of our role is making sure that we're providing good information. And so providing evidence-based information for people with cancer. We have the cancer.gov website, which is curated by panels of experts to ensure that this information is up to date, that it's really relevant, that it's something that people can trust. And recently has been restructured specifically to the topic of stomach cancer because it was felt to be needing better content and delivered in a better way. We get lots of traffic to these sites, including international traffic, and this is a major responsibility that we own as a part of the National Cancer Act of 1971 and really lean into to make sure that this is one area that we can be clear that the data is accurate and available to people. So why does this matter that we have good public support? So first, it matters because the funding that comes to the NCI, it's a lot of money, but it is involved in supporting a lot of different resources. I want to make sure that one of the take-homes that you get is how much of our national infrastructure of science is coming from funds that come to the NCI. We support research funding, and I'm going to talk about grants in just a minute. We also support the Cancer Center program that you just heard about, which is a network of 72 cancer centers across the country to ensure that we have strong both basic science, translational clinical research, epidemiology, and training in these spaces. We do workforce development. We provide other resources as well. And then there's operating expenses that come as a part of this. So let's talk about training for just a second. So we are responsible for the bulk of training of the workforce of the cancer researchers. That starts at the pre-doctoral level. So you don't have to worry about the names of the awards, but we fund people getting their PhDs. We fund people in MD training and other parts of that pre-doctoral space. We fund postdoctoral researchers. That's people getting their specialized training before they start their independent careers or go on to government or industry jobs. We fund lots of early career investigators, and then we fund late stage investigators. In addition to providing funding just to investigators, we want to make sure that they're successful as well. And so that funding goes to things like this in the middle, Nancy, is an app that was created by and for trainees to enable them to network effectively around their area of interest in research and to provide a tool. It's an AI-driven tool that lets them see this universe of publications that are out there so that they can navigate that much more seamlessly. We also provide podcasts. That's what the Inside Cancer Careers and other kinds of support tools. So where does our money go? So this is the money slide. So we provide about 45% of our funding goes directly to research projects. So research project grants, that's the bread and butter funding going directly to investigators. About 18% goes to investigators who are working in the NCI, that's in Bethesda and the surrounding area. More very specialized types of research that can only be done in our cancer center, in our clinical center. And then we have a variety of contracts, our support for training that I mentioned before, other research grants, and other ways that we support research across the space. So you can think about it, extramural is what we call the funding that leaves our campus and goes to investigators in a variety of different ways, from the cancer center-sized grants to the spores, to the individual, even to the trainee, and then intramural program to those investigators that are working here more locally. We get a lot of questions about our pay lines and our appropriation. So the purple line shows our total budget that has gone year over year. And as you can see, our total budget this year is $7.2 billion. It's actually down a little bit. There hasn't been a decline in many, many years. Our base went up. Our base went up by $120 million. You can see that's the blue line, but we were still receiving Cures Act money to support the moonshot. And that has expired and now is what is bringing us down a little bit. You can see in the orange color there at the bottom, the 21st Century Cures Act, and that's in millions of dollars. I have another slide that'll talk about pay lines in just a minute. So how we convert that into money that's going into the hands of our investigators. So this is the looking at what happens to pay lines. So there are two numbers that I want you to take home. There's pay line, which is what we publish, which is the minimum. So everybody who gets a score better than our pay line will get funded for sure. We have mechanisms to bring a few more in. So the pay line is the funding line. The funding amount is always a little bit higher than the pay line. So our pay line has on average been about 10, and it's 10 this year. We had managed to get it up to 12. When I say 10 and 12, that means 10% of grants that are submitted will for sure get funded. So that's 1 in 10. We have far more than 1 in 10 that are meritorious. We have far more than 12 in 100 that are meritorious as well. And we've been trying to push that number up, but it's been a challenge because the budget has stayed steadily flat. Knowing that one of the most important things that we can do is fund our early stage investigators, you can see the blue line is this year we kept the early stage investigators funded at 17%. So 17 out of 100 of a new investigator. So someone freshly trained, starting up their research program, they have a much better chance of getting funded. This is our way of surviving through this difficult budget climate. The final funded numbers, again, will be a little bit higher than this. If we're funding early stage at 17%, it'll come in 18 or something. I don't know until the end of the year. For the established investigator, been there, done that, the pay line's 10. In the end of the wash, it'll come out around 12. So not enough to be really what we want, funding the best of the best of research. I want to make sure you know, though, that we are committed to getting dollars out the door to these extramural investigators. So this is how we've been doing with funding in total amounts of dollars going out. And you can see our estimated number for 2024 is $105 million more than it was in FY23. Our increase in base pay was $120 million. So we tried very hard to make sure that almost every dollar that came in the door went right back out the door to investigators, because I know that's what we were intended, to make sure that we were continuing to fuel the best innovative research that's coming from our scientists around the country. And I'm not leaving you very much time for questions. I promise you I'm almost done. So when I talk about these dollars, the $7.2 billion, we do an assessment every year of what would it really cost to do the work. In fiscal year 24, the assessment for what we thought it would cost this year was $9.9 billion. We're getting an increasing delta in what it will really cost to be able to do the work that we want to do. We've made a guess for next year. What would it cost next year? We want to do the work we're doing today. We'd like to fund more grants that are meritorious. We would like to do more clinical trial research. That will cost, our estimate is $11.6 billion, $11.46 billion. We don't know yet what we're going to get this year. So how we're fueling progress, sorry, I know I'm just about out of time. Funding innovative research, fostering our workforce of tomorrow, engaging with collaborators, and leaning into the National Cancer Plan. And with that, I'll thank you, and I'm happy to take questions if I can.
You have 2 minutes on
I
the
kn-
roll.
okay,
Your
okay.
people say you have 2 minutes. Does anyone?
One question.
I'm so sorry.
You're the first one I see, so I'll give it the floor.
Thank you for the presentation. Tomorrow, a group of us are going up on Capitol Hill. What message do you want us to convey to lawmakers?
Yeah, yeah. I would say that if they want us to do the kinds of advances that they expect, we need more funding. We know there's a cap. We've made a good estimate of what it would really cost. It would cost between $9 and $11 billion.
Could I ask from a global perspective? The NCI's budget is one pot.
Yeah.
Industry is supporting research, philanthropy
Yep.
supports, and then there's
Yeah, and the
global
foundations. Yeah.
investment. Would you say what's your
Oh.
part of all of that and its role in that global investment?
Right. So in terms of funding foundational science, we're the world dominator. So that's
Tell these people what
you
you mean by foundational science.
So that's science in laboratories. That's the discoveries of molecules that are driving cancer, where cancer is coming from, how cancer evades the immune system. Those kinds of basic science questions that really have to be done in order for us to make the leap to clinical translation.
All right, we've got
Yeah.
to-
We need more funding.
I'm sure you have
Yeah.
another engagement.
I
this
do
afternoon.
actually.
Thank you
I have
so
to talk
much
to
for
them
coming.
at Congress today. So
Very grateful.
thank you so much.
Thank you. Thank you.